Andy.
So good to be here.
You know, Andy, the first day I went for my first interview at Health and Human Services, I was getting out of the elevator, and Andy was walking on, and I knew it would be a good day.
Was it a good day?
It was a good day. It worked out.
It did.
It worked out. I know, how many people know that stuff happened in health reform today? All right, check your Twitter feed if your hand didn't go up. I know you want to talk about that. I'm going to save some time for that at the end. I know we only have a half an hour, so this is speed dating with Andy. But I did want to talk a little bit about tech. So you've been working in healthcare a long time.
Mm-hmm.
Since before the iPhone was invented.
Yeah.
What's the thing you thought, technology-wise, it would really take root that never did?
You know, I never in a million years thought someday they would call big data AI. It's just incredible progress. Oh, did someone groan? I mean, the hard thing, it's a great question, because the hard thing in healthcare is trying to define the trends from actual just kind of fads. And I think the world looks so much more similar than it should to the way it used to relative to innovation. I mean, back then, e-prescribing was like the only thing people used their technology for successfully, and that's still close to true. So, you know, we haven't figured out how not to make technology something that consumes more time.
Right.
We need to make something that allows technology to save people work. So, I don't know, I think I would have probably supposed there would have been more progress than we've had.
Do you think, just as follow-up, do you think, have you seen changes in that sort of 20-whatever-year period in how the individuals react with their healthcare system? Or is it mostly the same and a little bit of innovation by individuals around the edges?
I think we love our personal technology more and more, and probably dislike our healthcare technology more and more. Like, people love hip chat, and they love their mobile devices, and they love the ability to record stuff and feed stuff automatically. But the big problems in healthcare, the inefficiencies in healthcare, have only gotten worse. The tangible, solvable problems, like the logistical problems in healthcare, are no better. The care coordination problems are no better. So we have to sort of judge technology not by the cool factor, but by whether any real problems have been solved. And I think many of the problems in healthcare are productivity problems.
Yeah.
And they're just as bad as they've ever been.
I wonder sometimes, at least in my own experience, whether the fact that I can do so much slick stuff with a supercomputer in my pocket makes me more frustrated with the healthcare system than would otherwise be the case, because every time I turn around, somebody's handing me a piece of paper, and at least I know, like, well, I could e-sign that. I have two-factor authentication. Like, you know, I do online banking. Why is this different?
Totally. And it actually makes doctors a lot more frustrated, because they know, like, they never use words like interoperability. They say, how come when my patient goes to see that doctor, I can't get a record back of what happened? Because they know that that's not a technical miracle. Right. Right? They know that we've somehow cracked that code, how to actually get information back and forth. But so they can't understand why. And they blame their EMR. And they're like, you know, and you know, they're such Luddites that they like want to shake, because they think the EMR is literally sitting in their computer. Like, I hate this thing. But you know, it's just
yeah. Well, that's true, and we could spend a whole half hour on health information, but let's not. Let's not. One of the things that I know this audience is really interested in, I've been asked about a lot, is as we try to bring health technology and health innovation into deeper root, and we've been working on this since, you know, just on the cusp of high tech, and billions have flown into it. How does it fit into the political realm? Is it like a Democratic thing? Is it a Republican thing? Is it popular on the Hill? Do people not like it? So putting aside coverage and insurance, which we'll get to, but for the tech innovation, what's the American sort of political flavor of that? I mean,
you know, innovation politically has been a Republican thing, because it's been kind of private sector, and, you know, generally speaking, the Republicans, this is to the extreme, think the private market will solve all problems. The Democrats think the government could solve all problems. They're both hopelessly wrong, and so there's much more nuanced and sophisticated answers. But you know, Democrats sort of stole the bacon on innovation during our time there, actually, I mean, owed to us, basically. Right, but really, like, said, you know, we got to push the envelope. We have to set a faster pace of change, because if we go about as fast as people want to go, we'll never get anywhere. And so we started to push the envelope. I think the new administration, and look, maybe they're going to change now that there's a change in leadership, and I think there's reason to believe that. I don't think they viewed the Innovation Center the same way. I'm hopeful, actually, because I think the new person who I think will run CMMI, I hope they leave that person alone, but I think that person is very, very good. And if that person ends up coming on board and taking things, that'll be great. And I think it's their job to communicate with all these people.
Right.
And that's kind of how we viewed it, right? It's just get out of Washington, engage in the community, and listen, and try to evolve our products.
But if we're sort of in this new era and we maybe don't have the purse strings of the government pushing us forward, what can we as an innovation community do to bring information and messaging to CMMI or CMS or the Hill? Like, what are the things we should be bringing to them? What are the stories we should be telling? What are the slick tools we should be showing them?
Yeah, have a success, right? Slick tool doesn't mean anything. Like, have a success with some data, you know, around, whether it's around diabetes reduction or something specific that they care about, that that's in their population. Like with any other customer. I mean, treat the government like it's, you know, like it's a $1 trillion budget problem.
Well,
and
it is.
They want to solve it, and it is. And if you bring them ideas and proof points, and those proof points happen to be things that get people better care closer to home in more comfortable settings at lower costs, everyone will listen to that. And actually, back to the point about, I do think Republicans more naturally will swim to that kind of story. You know, Democrats tend to be a little more suspicious of, okay, well, what's that? Someone's making money. This is something suspicious here. And, you know, we have to kind of disabuse Democrats sometime, some part of that. And so there will be, I think there's good opportunity, even in this climate where it's been a little bit flatlined.
So talk about value-based care, value-based purchasing, whatever we're going to call it. We did a lot of that work in the last 2 years at HHS. It's had some fits and starts in the last 9 months with the new rules and the new administration, the joint, the orthopedic bundle was yanked. But that kind of depends on doing stuff in a different way and disrupting these work patterns that you spoke about earlier. What's the place of innovative technology in advancing value-based care?
Yeah, I mean, what we're talking about really are payment models. And payment models are important, but they're important support structures. They're not important aims in and of themselves. So, you know, what you want to do is you want a delivery system that has a culture of focusing on getting people better, keeping them healthier, sending them home, preventing bad conditions from developing, and then you want to reward them for it. I don't think the reverse works. I don't think you can actually have someone practice better medicine or treat their patients better because you're paying differently, and you know, because you'll just find some other way of gaming the system. So the most important thing behind how we pay is what signals we're sending. You know, essentially what we're trying to communicate when we're at CMS is I'm trying to get in the mind space of that hospital CFO who's thinking about, do I build another building and add another 200 beds and try to fill it? Is that going to be a smart investment? Or will it be smarter investment to invest in preventive medicine, community-based care, and those sorts of things? And so you want to send those signals, and then you're also sending the signals to the other health plans, the commercial payers, so they'll get on board. So Medicare Advantage, I think, is probably the most interesting opportunity from a tech and innovation standpoint, because when you're in managed care like models like that, or Medicaid managed care where you've got a total cost of care outcome, people will be creative. Yeah. They will have an interest in adopting your product. Now, just because you come in and say this is going to lower someone's cost of care, right? They're going to buy that. But if you can demonstrate that, and if you can, and remember, if you claim it's the technology alone, no one will believe you. They'll laugh you out of their offices. But if you say there's a people process technology system in which our technology works and can help you accomplish these things, people will be very interested.
So where do you think technology and innovation is needed most in the healthcare? It's a big, complicated sector. It's got commercial, Medicare, Medicaid, devices, pharma, labs. Like it's a big pie, complicated. Where do we need the innovation the most?
Okay, so I'm going to share a little secret with you.
Okay.
Having run the Medicare and Medicaid programs, CMS, this is a secret. Don't let it out, okay?
But there are two M's in CMS.
Our problem as a country is not with the 65-year-old jogger with 2 Fitbits who records every time that they're going to be fine. They're not going to bankrupt the country. And I'll tell you what, I venture to say, I don't know all of you, the two of us. My guess is if one of you were to get sick or someone in your family member were to get sick, you'd get very good care. I mean, we're capable of providing good care in this country. The problem we have is actually with the woman who lives 2 bus stops away from a dialysis center. And if she misses her second bus, she may go into renal failure and kidney shock and all kinds of bad things happen, including losing her life and costing the system lots of money. And the thing to understand is, like, if you take 2 diabetics, and one of them is middle upper income and one is kind of lower income and has socioeconomic issues, and the lower income person index is at 2x what the middle income person index, but it's not because they have twice the blood sugar level, right? They have the same blood sugar level. What happens is the person with the middle income makes 98% of their appointments and fills 98% of their prescriptions, and the other person fills 60 to 70%. And so if you break down the problem that way, you all of a sudden start to see where technology can play. And I would make the argument that we need to shift our country's mindset of innovating in the things that we can relate to, like putting a Fitbit on our refrigerator, to things that actually move the needle on some of these very important, solvable, logistical problems around caring for vulnerable populations, low-income populations, populations that have other social factors. Like we know for a fact that if you intervene successfully in the first 5 years of life so that someone can avoid the adverse events of hunger and all kinds of social ostracization and behavioral issues and so forth, that the rest of their life, they cost a lot less and they graduate high school and lead a better life. We got to invest in those areas. And so the Medicaid program, I think, is probably the ripest for innovation.
Mm-hmm. But some of that innovation, I know from the work on social determinants of health, some of it is very tech-oriented. Some of it is just really simple coordination, community-based resource use. Some of it is enabled, like when a hospital who's now on an ACO contract uses an app to order a ride for their dialysis patient so she can get there if the buses aren't running. Or a really simple hack that was used post-Katrina, just a really simple Excel registry, who's on dialysis in the case of a catastrophe, so you can get them to a working dialysis center. That's really simple.
You're right. You got to think about tech differently.
Right.
It's like, if someone described Airbnb to you, would you call that tech?
No.
But, right, it's tech that makes it happen.
Right.
And so I think we are so used to thinking about, like, we talk about digital and you know, all these things to really remind people that we should have a high multiple on our companies and that it's very tech-oriented and it's very scalable. But the reality is, like, you know, you don't hear Airbnb calling themselves a digital company. Like, guess what? The rest of the world just uses technology. They just use it.
Right.
They actually do stuff, and then they use technology to do stuff. We need to focus on the stuff we need to do, like getting the woman to her appointment 98% of her time instead of 80% of her time. And then we all know that we can use technology to do that. And we just have to stop being so fascinated with the technology.
Right. It might be a Corolla that picks her up and not a flying car.
Right.
Right.
That's right.
I have one more question about tech, and then I will get to health reform, which is sort of, all right, so we call it tech, but it's not always tech, and sometimes it's this complicated mix of serving people and digital communications tools, because that's where the population is. Like in the rest of the world, it's not healthcare, it's just digital communication. But fast forward, everyone wants to know what the future is going to be like so we can bet on it in the stock market. 15 years, what do you think is going to have taken root? What do you think is going to be the thing that's the thing that's going to have a big impact that has a tech that was enabled by tech?
You know, I really hope that the answer to that question won't be some technical breakthrough. I mean, we know the way the world tends to work is something tends to take off, and then that changes everything. And I think we have a kind of too many of those miracle hopes for ourselves, not just in innovation, but in models. Like every 5 years, there's a new 3-letter acronym that has solved how we're going to pay for healthcare. We haven't told the patients about it yet, but they'll catch on eventually. Right. So I think I would like to see us get into a mindset of understanding patient problems better, listening to those problems better, solving those problems productively, and honestly, if 15 years from now, Lucia, we have added 30 minutes to a physician's day somehow, that's a really good progress.
Not 30 minutes of data entry or 30 minutes of
30 minutes to their clinical day. If we gave them back time, or if we give them back an hour of time, that's such a noble goal. And you've got to imagine that we'll do a lot of productive things with them. And by the way, because we're getting older and sicker, that's probably what we need to do just to stay even and to keep
we may want
employed.
that for ourselves.
You and me, we may need that if we're getting on. I'm older than you probably, but much older. But yeah.
So it's about creating better opportunities for people to communicate as humans about their health, really. And how can the tech, Sandra Hernandez spoke about how can we have tech take the unnecessary steps out of the process, or the steps that can be automated, let's automate.
It's the jobs thinking.
And the steps that have to be humanized, let's keep them human.
Mm-hmm. Yeah. Wow. No, I think that's, I wish we had that struggle. I think healthcare is going to be high touch because, we need people we trust in critical moments. I don't think, this is one part of our economy where we're not going to automate that away. But we can make it a whole lot easier. And we can make people a little smarter. I mean, we don't have to put every piece of information in the world at their fingertips. But we can make them a little smarter. And I tend to think we tend to over-engineer. Every new company in the MA space is building their own brand new predictive model about who's going to get sick next. And they're all going to be wrong 62% of the time, but they've got to build their own. When in fact, what they really probably need is some communication system that allows them to very quickly in real time talk to the people that have seen the patient and communicate information when they do, instead of rebuilding these huge analytic systems. So I think that's a little bit of our trap, is we've created an industry around healthcare technology before we've created any value in healthcare technology, or much value, and I think that's just a bit of an odd thing we need to overcome.
For example, we could just create a system for having caregivers get involved in the communication stream. I was seeing on my Twitter feed that there was, a new product. It's a pill that tells the doctor when somebody's taken it or not. I'm like, well, ask the person who's caring for them every day.
Right.
If it's a profoundly ill child or a very elderly adult, somebody is helping them and counting their pills and can go look at that box, as unautomatic as it is, and go, oh, you missed the blue one at noon.
Hey, I'll tell you what, you make a great point. My social media life is totally dominated by my relationship with moms of chronically ill kids. And if you think about it, the world's healthcare expert is a mom of a chronically ill kid. They know more about how healthcare works and doesn't work than anybody, and they know more about how to make it work. And they're more interested, and they're more vested in making it work. And so, they have the ability to assess and get the things they need through the communities they build, in all sorts of ways that are taking advantage of a lot of technical tools that people have built for other purposes.
Yeah, interesting. All right, turning to health reform. So there was some news today. I'm hoping you can sort of briefly summarize the news, make sure everyone knows how to follow you on Twitter to get it in greater detail in tomorrow's 16-tweet string or whatever you do. And also, what can we as individuals do? I love Andy's tweets.
Okay.
What can we as individuals do?
Did she sound sincere?
Of course I'm sincere. I know. But the last thing is, what can we do as individuals to sort of, if we're interested in this issue, especially ensuring people have coverage, what can we do? So those three things.
So people will ask me, like, what's the perfect health policy that solves all the problems? And it's totally the wrong question. As someone who came in and led the turnaround of the implementation of the ACA, I can tell you that it's far more important that we have something that we can implement. And to have something we can implement, we need something that both parties have their fingerprints on. And count me in the camp of someone who'd take half a loaf that everybody supports than a full loaf that's the most brilliant policy maneuver ever, but it's either only going to be as good as the party is in power, and then we're going to get a completely new system. We're going to play ping pong for the next election cycles, or that literally you have to fight against the grain to be successful. So been a big proponent of that. I joined the Bipartisan Policy Center. People might say, well, you're not the most bipartisan person, but the reality is I am. I don't think any of these issues are the least bit partisan. I think they're all kitchen table issues, and we need to rescue them back. So today, as a lead up to that, Senators Murray and Alexander, who are both co-chairs of the Health Committee, have been working together on this for some time, and you've probably all seen these news items, announced that they have a deal in concept, paper to be released Thursday. The next steps are they are each got to sell about 10 people in their caucus on getting on board. So I've been calling people, members of the Congress, to try to get them on board. Alexander and his team are doing the same thing. And we will see what happens. I think it's funny. I can tell you because I've seen the details of this deal, and it is on my Twitter feed if you want to look at it. But you look at this deal and you'd say, forget who wins and who loses. Let's ask a different question. Do the American public benefit? And the answer is the American public benefits. They'll pay less. Nobody will lose coverage. There'll be more predictability. It's all good. The hard part's not agreeing on the policy. The hard part, actually, at this point in time, is neither side can stand to see the other side claim they won something. And that psychology is so infected in our culture right now that as soon as Trump says he likes it, everyone on the Democratic side says, well, can't trust it, this is terrible, can't do it. As soon as the Democrats say, hey, this preserves the ACA, then the Republicans say, this must be bad, we can't do it. And so it's got a journey to travel. But I would encourage anybody who is interested in some sanity of just having some predictability to not support it in a partisan sense, but just to support it in the sense that says, you guys have to work together or we're going to throw your ass out of Washington.
And just a tip. Just a tip for those of you who are new to politics, Andy often tweets who needs to be contacted. And if they are your representative, constituency really matters. They listen to people from their districts. So think about who your congresspeople are and who your senators are. If you're in Tennessee, call Lamar Alexander. If you're in Washington, call Patty Murray and say, go Senator Murray. But it really matters. So you can find those tips on Andy's tweets and tweets that he retweets, and you can always look that up in the newspapers. I know we're running out of time. We're going to take a couple of questions from the audience. I just wanted to ask one more thing. You've been cooking up something for open enrollment this year. Can you just briefly talk about what that is?
Yeah, so I'm one of the national chairs of an organization called Get America Covered, hashtag Get America Covered, hashtag Get Us Covered, hashtag Get US Covered. I think I got them all. And essentially because the Trump administration has refused to support open enrollment, and in fact, Trump just told America that there is no more Obamacare. So that's confusing to people. And it's confusing people who need coverage. I never sort of I know that these words are in his mouth and he feels the need to say them, but they're really, sometimes they just need to put a piece of tape on that mouth, because that's not a good thing to say, even if he thinks it makes some sense politically, which in this case, I'm not sure it did either. So we have to let people know, because we actually know one thing about open enrollment from doing it for 4 years. If you ask people who aren't insured, would you like to have insurance? Most people will say yes. I'm sure there's some people that will say no, but most people will say yes. If you ask them why they don't have insurance, almost all of them will say cost. And if you say to them, there's tax credits, and 80% of the people who come on the exchange find that they can get a policy for under $100 a month, they don't know that. Nobody knows that. That one fact, that's the only fact they need to know. When they know that fact, some portion of those people get covered and are grateful for it because it's for the first time in their lives. They have coverage for their family. And then their kids can play on sports teams when before they don't let them play on sports teams because they don't want them to get injured. So getting that fact out, it's a very simple message. And we need to get that fact out. So we started this organization. And I think everybody can be helpful in that regard.
So pull out your phones. Hashtag #GetUSCovered. You can follow it. There'll be lots of details there if you want to get involved. All right, moving on to some of our audience questions. We had a number of questions about social determinants of health and Medicaid space and ROI and innovation, and I'm going to try and bundle them all together, which is, how do we...
What's the ROI?
Well, how do you prove ROI?
I'll tell you. I have an answer.
Excellent.
I have an answer. Here's a really interesting secret on how to make money. Lose less money, okay? So Medicaid patients, hospitals will tell you they lose money on Medi-Cal, Medicaid, wherever they are. So guess what? If you can prevent an unnecessary hospital visit, let's just use rough numbers, hospital saves $5,000. If you can prevent an unnecessary ER visit, hospital saves $1,000. If you can prevent an unnecessary clinic visit, maybe the hospital saves $50 or $100. You can see them in their home and keep them healthy. Maybe they're starting to make money. So you've got a built-in incentive in population health. And guess what? We want to be able to go to care for people in their communities. That's what this is really all about. And so the ROI is very, very simple because it's not like they're trying to fill their hospital beds with Medicaid patients. They're not, but they have to learn how to work within the social determinant of health context in order to solve that problem.
Sort of the Camden, New Jersey is a great example of this, and they had a project many years ago where, it turned out that half the people showing up in the ER needed shoes and the other half needed a turkey sandwich. It wasn't a tech solution at all. It was recognizing that the reason they came is because they were cold and hungry. So serve the cold, address the cold, address the hunger.
Feed a fever.
Exactly, exactly. So I'm gonna try and do one more. So there's one question here. Can we ever achieve consensus on how to measure healthcare quality and then take action on that consensus?
Boy. I think one of the challenges we have is so let me just try to give a more direct answer. How about measuring it based upon the basically patient-reported outcome as a start? I mean, how about just starting with, patient comes in, says they can't walk up 3 flights of stairs, patient reports they can pick up their kids and walk up 3 flights of stairs. I mean, at some level, unless there's something sort of very, very clinical that the doctor's going to be able to read in a lab result, which I think is all sort of stuff that's in the books already, that's going to be the best you're going to have to do. And when we can't do that, we make a horrible mistake. We make a horrible mistake. When we don't know the answer, we overmeasure. We decide if we don't know the one thing we need to know, we decide we must need to know everything. And that's how we get into this trap of all this over-reporting and over-recording. And that's what makes our technology break, because our technology's got to do all these things, and a workflow becomes impossible. So it's a little bit of the root of some of the evil. I've
been waiting for that, the tech that is a portal. It's something that comes to me as an orthopedics patient, and it says, can you walk the same now that you could before you were injured? Simple question. So that's an example of how we survey. We can use tech to survey, and maybe that's something that's a simple way.
I think so.
All right, we're almost out of time. I know you've joined the Bipartisan Policy Center. What else are you going to be doing in the future, Andy?
Stay tuned. Stay tuned. That's not for, when are we, October? That's not for October.
Not for October. Do you have a month when we should be tuning in more astutely?
It rhymes with Ranuary. Yeah, there'll be some clues, I think, that will probably pop out between now and then, but I think it's going to be exciting and hopefully good for the country, I hope.
But you're not running for office.
Not running for office.
All right.
I've learned that every time I give an answer to that question, someone says, he didn't answer the question. He left himself wiggle room. But I'm not leaving myself wiggle room.
I know, you put the nail in that coffin.
Yes, I put the nail in the coffin. I've tried to endorse somebody for every office people ask me about. So
yeah, and you're going to vote, right?
And I'm going to vote.
Yeah, don't forget to vote, 2018. I think we're out of time. Thank you, everybody. Thank you for your questions. Hope you enjoyed the conversation.